Yeah. So I learned some basic things, and because I was familiar with Brazilian Portuguese, which is very different. So I can sing really good in Portuguese, but don't ask me to speak it. I must have gone into the studio 5 times to fix things. So, because I kept playing it for other people too, and they're like, "No, you pronounced that word wrong. No, you have to change the ending of that." So, Portuguese is a musical language, that's for sure.
Amazing, amazing album, by the way. So anyway, um, so this morning, um, my morning bite, it's about doing procedures atypical for a provider. Um, Today I'm following up a year follow-up of about a biopsy pathology I did in a 50 years old Caucasian long-standing lesion endoperio. We didn't know what was first. Several root canals, anterior, that'll be 11 and 12 in Australia. Here will be 8 and 7. So those are basically, anterior teeth, smile, in a lawyer. Definitely, you wanna check all the boxes. So we did the biopsy. Was a greater of a centimeter lesion. Typically, when you do a greater centimeter, you do an incisional biopsy because you want to make sure it's nothing, malignant or even benign. Because sometimes benign lesions can also be very, very destructive in the job. Pathology is one of those things that I love doing pathologies or learning, whatever, because it's just almost like a game. Like, what is this? I need to know. It's you have to love it to do it. My bottom line is every time you do procedures that you are not a specialist, you are held by the standards of that specialist. My root canals, my perio surgeries, my oral surgeries, my pathologies, my Juvederm, Botox, everything I do, even though I'm not officially that, I do it following protocols of the Endo Association, the Pathology or Pathology Association, and send to regular reports. I want to make sure, I have a backup of an extra set of eyes. Pathologist, I tell the patient it takes me a minute literally, and it will give you a peace of mind. 90% of the time it's nothing, but that 10% when it happens, it's really, really, and it's all about, getting it at the right time. Prevention is the key. That's why when I do the periodic exam, the last thing I see is teeth. I start from the outside, going surroundings, throat, tonsils, everything. Whatever we have, we use a light. At this point, I'd throw anything. My training was in also hospital settings. We did a lot of cancer patients. It's one of the most rewarding things you do in prosthodontists. They're so grateful with anything you do. They're just happy to be with us, and we're happy to have them. So typically, cancer patients are the most grateful people you will ever have in your chair. Never dismiss a cancer survivor, especially oral cancer survivor. It's one of the most invasive, like it goes out really quick. That's why we're so proactive in our practice in Island City Dental. Listen, it might be just biting the cheek, but it just takes a couple $100 to give you a peace of mind. That's it. I was just talking to one of my mentors, Dr. Nancy Rotroff. She's amazing. She's the same. She's a general dentist, but she's been 40 years in experience. And she said, "What you're gonna watch? how it's gonna get worse. Just and we do everything like that. A small lesion, small open. The only reason you wouldn't be proactive in a patient is because a systemic condition will prevail you to give a benefit to that patient, meaning blood thinners, cardiac, immune, 100 years old with a very, very, weak general health, recovery cancer patients in remission. You have to just watch, you don't extract, radiation history, bisphosphonates. Now this new kind of bisphosphonates, which are not bisphosphonates, they're biologic, that it will prevent things, but we don't still know how to treat them, so they can cause pretty much the same of a bisphosphonate medication without us knowing what to do when it happens or prevent it. So there's a lot of guessing. But if you are healthy, if you are, just diabetic, high blood pressure, cardiac stent, things like that, in my office you're getting a biopsy, just because it will be a small inconvenience for something that it's not even the patient at this point, it's me. I want to sleep, the very little sleep I get, I want to have it well. That patient is not going to turn in something else, and I scare patients because I've seen it. I've been in the board where patients are there sitting with a huge lesion. They have an oxygen tank. Family members are there just holding their hands. And there's oncology, there's a chemo, there's a pathologist, there's speech therapists, there's this, there's that, and they're us. They don't even know how to pronounce us, like our name. Like, oh, where's the guy with the dentures? Where is he? That's us. Because at the end, if the patient has a cancer in one of the jaws, in the tongue, in the eye, in the nose, we end up doing something. There's a subspecialist that it's very, very like, if prosthodontist is this specialty, it's like this. It's called maxillofacial oral prosthodontist, which is basically a person that treats, cancer patients, trauma, accident, congenital missing stuff, like nose, eyes, ears, or any of those. I trained with a prosthodontist, with three actually. I'm so lucky. These are Dr. Barry Shidman, Dr. Chu at Nova. Barry Shidman was in both UF and Nova, and then Dr. Chu at Nova and Dr. Seltzer at Nova as well. I just ran into him in the meeting. It was so nice to see that guy. I mean, I'm like, I want to be here. I mean, I want to be him when I'm like 85. He is the most sharp mind you will find around town. But anyway, so those guys did a year, maybe 2 years after prosthodontist, which typically takes you about 5 years between general residency, then you figure it out, you do 3 years of pros, sometimes 4, and then you are like, hey, I want to even do more, which is restoring these patients with a lot of missing, with a lot of history, like the recovery, cancer is gone, but now they're missing the whole upper jaw, the tongue, the lower jaw, things like that. The knee, the ear, the nose, the eyes. One of the most impressive thing I've seen, it was Dr. Barry Shidman replace the whole face. He practically was the one that inspired. I mean, there were, I would say, 5 people that inspired me to continue my dental journey, because I was like, I want more. Because every time I run into these people, they make me feel like I need to learn more. And they got to the point that I was like, listen, I need to stop. because I need to make a living. I'm not getting any younger. I want kids. I want that. So I said I almost got into a fellowship in maxillofacial prosthodontist. I did some with Barry Shidman, or he made us get exposure and all that, because you never know what's gonna, obturators are the most basic things you can do in dentistry. Literally, with Dr. Shu, I did one with Dr. Barry Shidman. I saw how he does it, how his follow up, the protocol, all that, and it's the most basic treatment you could do in a patient, and they will be so happy. With Dr. Sawish, we saw follow-ups. I was I wasn't even in school, back in school in the States, and I knew what an obturator was because I was treating it with Dr. Sawish, or at least helping him to treat it with Dr. Smith. He does a lot of those. He's amazing, Dr. Smith. So my bottom line is, every time you do anything that is out of your scope, do it at the standards of that specialist. That's one thing I learned in my AGD, University of Florida, which is like a general dentistry. 2 years, they teach you everything about dentistry, but in more depth than just dental school. Meaning, I do endo with a microscope. I do oral surgery with all the consents, all the techniques by oral surgeon supervised. I do pathology by oral surgeon, Dr. Granda in Miami. That guy, it's an eminence. He doesn't know how sharp is he. That's how he's a military oral surgeon trained. Those are gold, like diamonds. If you run into an oral surgeon trained in the military, please listen to them. They are beyond. So my bottom line is, every time you do anything, the simple crown, that crown needs to be at the standards of a prosthodontist. It's not because we are nerds in the pedestal. No, because we've written the literature 5 years. At that point, we know what to do, what can be wrong, what can go wrong, what can go excellent. If you do a veneer in the person that cleans the office, whatever, do it as Dr. Baba from ACP, the president of ACP, will be doing it. Think big. You never go from thinking big. That's Dr. Smith's philosophy. He does not dismiss anybody. He treats everybody like everybody it's the king or queen of, England. And that's how it should be. So anyway, this is my morning bite. You can do Dr. Smith. He's everything. Oral surgeon, endodontist, periodontist, sometimes pedodontist, special needs, everything, but he does it with the standards of that specialist. That's the key. You will never go wrong doing that. And if you don't feel like going through the whole hassle, just refer it. We're here for you. Better together.